Just arriving now, but we would like to get started, so if I may. Welcome today. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us today as we continue our series on health informatics tools for the future. We also welcome those of you who are joining us via our webcast of this seminar. I really appreciate when we have not only an audience live here, but also coming in via the web. Recordings of these seminars are also available from our website 24/7, so feel free, if you can't make one of our seminars, to see it later on. A special welcome to our speaker, Professor Jim Anderson from Purdue University. I will not introduce Jim, as David Johnson will do that in a minute. I've had the pleasure of spending a little time with Jim this past evening and today. I must say that we share some similar interests, not only in health informatics, but in birds and other things. And you must take a special note if you're coming in via the web or in the audience or via the recording of Jim's beautiful tie. It has a number of beautiful birds on it. Perhaps Jim, if he has a minute, he could share with us a tale or two about his interactions with geese. A special thank you to our seminar series sponsors, McKesson, VON Canada, and Healthcare Information Management and Communications Canada. Without them, we could not do this series. Before we begin, I have a couple of announcements. Our next seminar is Wednesday, May 5th. Mike Connolly and Brendan Seaton from Smart Systems for Health Agency will be our guest speakers, and they'll be speaking on managing risk in health information systems. This will really be a very interesting talk, so I hope you can join us at that time. One other additional information, I have a couple of flyers here if anybody's interested in taking one. It announces our Health Informatics Boot Camp, which will be held this summer from July 17th, starting Sunday evening, and continuing on Friday, July 22nd. It will be an intensive one-week course, 9 to 5, with some time off, of course, in the evenings. And we'll be looking at all the basic concepts of applied health informatics. So if you are interested, or people in your organization are interested in registering, we're looking for participants. So there's a little bit more information in this flyer. Without any further ado, please welcome David Johnson, President of the University of Waterloo, who will introduce our speaker.
Thank you, Shirley, so much. I'm delighted to be with you today, and I'm delighted that Jim Anderson's presentation is going to be webcast as well. Let me just say a word about Brendan Seaton and Mike Connolly coming next week. I know them both well. Mike is the Chief Executive Officer of Smart Systems for Health Agency, and Brendan Seaton, a senior official with that body. I have the privilege of serving on the board of the Smart Systems for Health Agency, and it's a very key agency in Ontario's effort to establish the electronic networking for our health systems. In fact, one of the reasons for setting it up relates well to the title of Jim Anderson's address today, the human side of health informatics. As all of you know, there's a great deal of concern about privacy and security with health information in electronic form. And one of the motivating factors to establish a Crown corporation separate from the Ministry of Health was to manage in a more effective way the issues of privacy and patient-centeredness. Smart Systems for Health Agency spends about $100 million a year on providing the backbone for health informatics in Ontario. It's a work in progress, and I know you'll be very interested in hearing Mike Connolly and Brendan Seaton comment on it as a work in progress and where we are. I'm sorry that I have to leave you and cannot stay for Jim's entire address today, and I've presented my apologies. A little later this afternoon, there is taking place the President's Colloquium, Kathy, on teaching and learning, and I feel a little bit like the body at an Irish wake. It's essential that I be there for the proceedings to start, but I'm not expected to say very much or contribute very much, so that's where I will be. I'm so pleased to introduce Dr. Jim Anderson to you. His bio, or short excerpts from it, are in front of you, and you can read it for yourself. Let me simply underline that he's a fellow of the American College of Medical Informatics, a relatively new development which tells us something about this fascinating field of health informatics, professor of medical sociology at Purdue and professor of health communication at Purdue University, and will be speaking on the human side of health informatics. I think what Jim's credentials suggest and his title suggests is how broad and extensive is this interesting field of health informatics, and how important it is that we have contributions from a number of deep disciplines, including the discipline of sociology. And he's at Purdue, university which this University of Waterloo especially admires, and I have admired for a very long time, not simply because they're called the Boilermakers after a very famous faculty of engineering, but I was telling Jim that we have the largest faculty of engineering in the country here. We're very proud of it. We have the largest faculty of mathematics in the world. But largeness does not necessarily make quality, although we think in our two cases it does. And very clearly the Faculty of Engineering at Purdue, which is, if not the largest in the United States, certainly one of the largest, continues to be one of the leading ones and has been that way for decade upon decade upon decade. So it's possible to have very large size and very, very large quality. Let me just finally underline several points that appear in cryptic form in the biography before you about Jim Anderson. One is this issue of what investments we make in health informatics. I've said to gatherings here before that in this country where we believe we have a relatively sophisticated banking and insurance system, which does compete well on a worldwide basis, we're currently spending somewhere between 7 to 10% of the overall revenues of those institutions on informatics of one kind or another. And there would be many in those institutions who would say that's not enough for them to protect and enhance their business. In fact, in the health side, it's less than 1% that we spend of our total expenditures or investments on the informatics side, and one could triple and quadruple that and still not make enough of an investment in this important sector. Let me also call attention to Jim being authors of numerous books. The titles of two given here, and let me just read them out because they tell us so much. One is Evaluating the Organizational Impact of Healthcare Information Systems, Ethics and Information Technology, a Case-Based Approach to a Healthcare System in Transition, and secondly, Evaluating Healthcare Information Systems, Methods and Applications. As we think where we are in this country, in this marvelous and important adventure in health informatics, these two books and the contribution of this kind of very, very thoughtful as well as broad thinking is absolutely essential to the kind of progress we want to make. So, Jim, it's a pleasure to welcome you to the Waterloo campus, and we look forward to what you will tell us.
Oh, thanks. Thank you, Dave. Thank you, David and Shirley. I guess with the urging of Shirley, I'll digress at the very beginning, not the end, to tell a goose story. My wife, a number of years ago, acquired 2 baby geese. Our son was at college, and he came home with 2 day-old baby geese and to give to my wife, because as a child she had some baby geese that unfortunately ended up on the Thanksgiving dinner table, much to her sorrow. So these geese became eventually 25-pound geese with about a 6-foot wingspan, and they were both males, and they hated me, absolutely hated me. But one time we were having some remodeling done on the house, and the workmen didn't show up. And my wife went out finally looking for them, and they were up in the back of the pickup truck, and the geese were sort of circling the pickup truck. They were absolutely terrified of those geese. So they would follow my wife anywhere, but anybody else that came near the house, those geese would attack. So they were, unfortunately, they died last winter, finally, after about 25 years. But they were certainly a subject of much amusement within our family. Well, with that, as I say, as a digression, let's talk about information technology and healthcare. Obviously, I think we all know that information technology is becoming more and more intricately involved in healthcare in many ways. But let's look at some issues here about that information technology. The recent report by the U.S. President's Information Technology Advisory Committee stated that one of the most fundamental and pervasive problems of healthcare delivery is the paper-based medical record. From prescriptions to medical histories, life-critical hospital charts, patient care today relies on an increasingly antiquated, costly, and error-prone system of pen and paper notations. At the same time, the potential of information technology to reduce the number of medical errors, reduce costs, and improve patient care is enormous. Now, having said that, let's look at sort of the implementation of information technology and see how far we have progressed. And I pulled some statistics on a number of patient care tools, electronic medical records, clinical decision support systems, electronic prescribing, online communication with patients, and remote disease monitoring. Other applications have moved ahead very rapidly. The so-called knowledge enrichment uses and all among physicians has paralleled certainly the general public's use of the internet. For example, 90% of physicians now report that they basically go onto the internet to look for clinical kinds of information from the journals and so on. About 80% indicate that they read articles that are on from websites, and about 45% use it for continuing medical education. But when we start talking about using it in terms of as patient care tools, the percentages are much lower. Here are some comparisons of the U.S. with other English-speaking countries, Canada, Australia, New Zealand, and the U.K. You can see that the U.S. and Canada are way behind some of the other countries. About 17% of the primary care specialists in the U.S. and about 14% in Canada report that they use electronic medical records. But when you go to New Zealand, it's 52%, and in the UK, it's almost 60%. And so certainly there's an enormous gap here. And then if we compare ourselves with other European countries, you can see that we lag behind a number of these European countries. I mean, look at Denmark at 62%, the UK at almost 60%. Look at Sweden here with 90%, and the Netherlands with 88%. Overall, the European Union, about almost 30% of the primary care physicians use electronic medical records. So there certainly is a real gap when we compare North America to these European countries, and even, as I say, to Australia and New Zealand. The same thing, also, I just recently saw some statistics about hospitals. Less than 10% of U.S. hospitals have adopted electronic medical records, and only about 2.5% have adopted computerized physician order entry systems. But if you compare that again with Europe, only a little over 2% of European hospitals have adopted computerized physician order entry. So even in that regard, there's a huge lag even in the European countries in terms of hospital adoption of these systems. Here's some more statistics on electronic prescribing. Again, you can see the United States and Canada are very low, 9%, 8% respectively, whereas Australia 44%, New Zealand 52%, and the UK way up there at 87%. So again, this is very interesting that North America lags well behind these other countries. And again, with the European comparisons, you've got Sweden, the Netherlands, Finland, where you've got a large number of physicians using this. And I guess this is practice websites. Okay, this is practice websites, excuse me. With practice websites, but that 39% in the United States is a little bit higher. Here's use of PDAs in practice. USA about 17% compared to other countries, but this is a little misleading because, again, I saw a recent study of the use of PDAs, and it indicated that physicians are using them more, but they're basically using them for more administrative kinds of purposes and all. They're not using them for clinical purposes. If you look at surveys, about 7% say they order medications with PDAs, about 6% say they access patient records, and only about 5% look at lab results. So again, the clinical use of even PDAs is very low in the United States. Unfortunately, I didn't have any comparable statistics for Canada, so I don't know what it is in Canada. Online communication with patients. Patients overwhelmingly want to communicate with their practitioners, healthcare providers online, but only about 1 out of 4 have any kind of online communication with patients, and that's pretty limited. And use of remote disease monitoring, only about 5% of the physicians indicate that they're using that in the United States. This one in particular, I think, is important because certainly with the increase of the elderly population, with the increase of chronic diseases like diabetes and so on, the costs of providing care for chronic diseases is rising very rapidly in United States, Canada, and Europe, and all. And certainly these kinds of systems really provide a great deal of potential, but again, they've been very slow to diffuse in the United States. This says, okay, now take a deep breath. So this sort of suggests that these disease monitoring systems may be a real potential for the future. Reasons for using information technology. Some of these are pretty obvious, and again, coming from surveys. If we look at reasons for using electronic medical records, physicians say efficiency and better care, which is pretty obvious. If you look at electronic prescribing, again, you get efficiency and better care as sort of the top reasons for using the systems, but also formulary compliance, because that's obviously problematic for physicians when they're dealing with so many different insurance plans with different formularies and so on to essentially be able to obtain that information. Online communication with patients. Number one reason that physicians give for this is, even though they don't use it very much, is 41% indicate patients want it. Patients really ask them about it. There's a great deal of satisfaction with those practices that actually have online communication, and so that's much more patient-driven. Also, again, efficiency and better care are reasons given for remote disease monitoring. Whoops. This says, I posted your symptoms on the internet and got 17,513 second opinions. Consumer use of the internet has certainly increased, but most of that, this is a survey that we did, national survey that we did about two years ago, and clearly obtaining information about disease and symptoms and so on is clearly the number one use by patients and consumers, and even information about like locating providers, about a third of them indicated that. But you can see the other kinds of uses, online support, purchasing supplies, actually having some kind of online record, provider communication is still very low. And of course this reflects the fact that a lot of those services are not being offered regularly, routinely by physicians and all, and so that certainly indicates that patients, that's a big reason why patients aren't using them. But if you ask them what would they like, again, communication with providers, 56% of our national sample said that's what they would like, and and remote disease monitoring was very high among people with chronic diseases and all, and so there's a disconnect here in a way. The public really wants these kinds of services that are provided through information technology, but physicians are very slow to offer these services. Yes, sir?
Provider there mean medical doctor, is that what it means?
Which, I'm sorry?
You say communicating with the providers, I'm wondering if that means with sales operations.
No, pretty much we're talking about with practitioners, with the healthcare providers, with physicians' offices and clinics and so on, is the way this question was asked. Okay, so this leads us to the point of saying, well, why is this so slow? I mean, if patients want it, if physicians say overwhelmingly they realize they can offer better care, that this would be a more efficient way to offer health care, why aren't they utilizing this information technology? And of course, a lot of that comes down to things like lack of access to capital or cost, lack of standards, and interoperability here, that all the vendors essentially have different systems and they can't communicate with one another. Privacy concerns is another big factor. And finally, healthcare provider resistance to implementation of a number of these systems. So let's take a look at some of those barriers. For example, here again is our study of patients and all, where we asked them what did they perceive as the barriers to internet use, and you can see about almost 40% said privacy. And I think this is going up even more. I think I just saw a survey that indicated that more like over 60% of people in a national survey that I think that Harris Interactive Poll just released now indicated that privacy was a #1 concern here. And certainly those privacy concerns have been heightened by the disasters with LexisNexis and so on, with some of the apparently inappropriate use of data from these companies and all, and recently that have been disclosed and all. So that certainly is a major concern. Another concern gets into things like problems evaluating the reliability, the veracity of information that's provided on the web. As you all know, you can do a Google search or something and come up with thousands of websites, but then essentially not only sorting through those is a tremendous problem, but sorting out the wheat from the chaff. I mean, determining which of those are really reliable and which of those are not. You know, a lot of those are thinly veiled promotions, lots of times for alternative medicine, and many of them are not based on peer-based literature, and certainly patients have a hard time sorting that out. And so that certainly is another factor. And we have not evolved a system, even though we have seals of approval, but they're voluntary, but we haven't really evolved a system of somehow helping consumers to sort through the better websites, even though I think we all can name a couple we have some confidence in, certainly things like PubMed and so on. I think Canada has an excellent similar kind of a website that the government sponsors. But then when you get into the private sponsored ones and all, some of those are sponsored by pharmaceutical companies, but pharmaceutical companies don't put that information up front. They're obviously promoting their products. They're not there to advise you about other products. So it's caveat emptor or caveat viewer, basically in this case. And then a number of patients said that they were concerned about disapproval of physicians, that physicians aren't that keen on having patients who come in who know more about the new treatment regimens than they do, or who want to discuss in detail several hundred pages that they have printed out off of websites, and the physician feels, hey, I'm not being paid to sit here and help you go through all that and listen to you or explain this to you. And so there certainly, again, are problems here in terms of how do we develop a system to assist consumers to manage their health care more on their own, and to go sort through to sort out the reliable information here from the unreliable information. That certainly is a challenge at the present time. When we look at reasons given by physicians, like for not using EMRs, cost is certainly #1. Also, there's some concerns about physician-patient relations, but cost is certainly #1, and that's certainly a very real concern. For example, some figures that I saw recently indicate that a large hospital can easily spend about $30 million implementing an EMR, and that doesn't include the cost of maintaining it on an ongoing basis and updating and maintaining it. And even smaller hospitals, 200 beds and under, can easily spend up to $2 million for the initial implementation, and that's only the beginning. And if you look at physician practices here, these electronic medical record systems for physician practices can cost anywhere from $15,000 to $50,000 per physician for the practice. I was telling Shirley in a conversation the other day that our youngest daughter is about 2 years into a practice in Indiana after finishing her residency, and with one other physician, and she has to go to 5 different office sites and cart around a big box of medical records with her because they don't have any kind of electronic medical record system and all, and she's trying to get the practice to invest in an electronic medical record system, because not only is that a pain, but if a patient makes an appointment at the last minute or shows up and there's an emergency or something, like, she doesn't have the medical records. She basically has to try to reconstruct that by talking to the patient, and so it's pretty obvious with multiple sites and all that this would be a tremendous asset to the practice. but the physician, the older physician who basically owns the practice, doesn't want to spend the money that it would take to implement an electronic medical record system. And so there in my own family really illustrates this problem very nicely and all. Reasons for not using electronic prescribing. Again, cost is one big factor, but this is another big factor, MD-patient relations. That is an interesting thing that kept coming up. And here's an example of the kind of thing that is occurring. This is a computerized physician order entry that was used at University of Pennsylvania. Maybe some of you saw the recent New York Times article on this, where they identified 22 types of persistent errors in their computerized drug delivery system. And doctors reported that antibiotic administration was delayed because the system related lapses in getting drugs approved. 12% reported trouble telling which patient they were ordering drugs for. And so these systems are not foolproof, and in fact, in many cases, they have technical problems that clearly cause physicians to question their use and, in a sense, to resist their adoption. Here's a says, well, www.whatswrongwithme.com says it's just a virus, but I came to you for a second opinion. Reasons for not using online communication with patients. The number one issue here with physicians that's cited is certainly, again, understandable, and it's security and privacy. And the second one is the issue about non-reimbursability here. The security and privacy issue comes up because of these lapses, and this illustrates it nicely. It says, smile, you're on computer, your medical records, your financial records, your purchases, your subscriptions, your social security number, your phone calls, all of this is available, and it is. That's what people were getting into LexisNexis for and ChoicePoint and all recently, to get that kind of information, because they are large companies that essentially collect information on consumers and then sell that, and that information sometimes is very, very detailed, and so it's available. And also we have breaches, constant breaches. Here's one that just was announced about a week or so ago, where the San Jose Medical Group in California said they had to, California is one of the few states that requires breaches of security like this to notify the people affected. Surprisingly, the United States at least, only California, as far as I know, is the only state that absolutely legally requires them to notify people that maybe your information has been stolen and all. And this is a case where somebody stole some computers out of an office there that had billing records and sensitive information on billing and so on about 185,000 subscribers to and patients there at the San Jose Medical Group. Again, you know, this certainly is a very real concern, and there's not only the issue about hackers and breaking in, but in cases like with ChoicePoints and LexisNexis, people simply purchase the rights to that information, and the companies have no control over what it's going to be used for, who really is a legitimate user and who wants to use it for illegitimate purposes. You pay your money and you get access to the information or the data. Also, there's the problem here with things like email communication about authentication. Somebody sends you an email, you absolutely have no way in most systems of authenticating that the person who's contacted you is really the person that they say they are. I mean, virtually it can be anybody that has the ID and password for that individual, and this is particularly critical with sending patient information or sending detailed information to and from physicians or hospitals to patients. It also raises a number of legal kinds of issues. This is another impediment to physicians using email with their patients and all, because then there becomes the question of is the physician essentially liable if that information goes astray? Is that part of the medical record? Can that email transactions be subpoenaed in malpractice proceedings. There are a whole series of legal issues here around the transmitting of medical information, as well as the HIPAA requirements and the laws that have been passed in the United States about that. And so this is an area that is inhibiting the use of things like communication, email communication with patients. Also, oops, why that jumps like that. Also, there really are some egregious kinds of situations. This is one in particular that's rather egregious, where a woman in Texas started receiving letters that had personal details, information about her, and threatening her with rape. It took her about 6 months to find out where these letters were coming from. She actually had to hire a private investigator, and she found out that a convict in one of the Texas prisons was entering data for a data mining company, and that she had filled out one of these product questionnaires in order to obtain some free health care products and all, and so this information was being entered by convicts, and this convict had started contacting her. Well, she tried to sue the company for this, and actually the courts took the position that since she had voluntarily provided the information, that she had no right to sue. So it's, as I say, a rather egregious breach of security, and so essentially once that information gets out of the doctor's office or the hospital files and all, there's very little, if any, kind of control over what that information is used for, who has access to that information. And so these are issues that really are impeding some of this technology. Whoops. Another one is issues having to do with conflicts of interest. When physicians or healthcare providers put up like websites and provide information, there's this issue of conflicts of interest. This is a particular case that occurred because Dr. Koop, who was a Surgeon General and was very well respected in the United States after he retired, and essentially lent his name to a company that put up a website, drkoop.com, which was very well regarded. Well, the New York Times essentially blew the whistle on the fact that in return for listing products and services, he was getting about a 2% commission on these revenue, on the revenue from these goods and services. This is not something that was stated at all on the website. Even worse, the website listed what they called sort of the premier healthcare providers in the United States. And so people took this at its face value, and apparently the way you got your name on that premier list was you paid $200,000 to the corporation. Again, the website didn't state this. You say, well, look, don't we have to sort of somehow indicate what's advertising and essentially what's objective reporting of information? I mean, we get that in newspapers and magazines, and supposedly it says an advertisement when they have a big advertisement for medical products and services and all. But many websites don't make that kind of information readily available. And so certainly this is another issue having to do with websites and physician communication with patients and all, especially if the physician is essentially going to derive income from the providing that service or information. A lot of people don't realize that pharmaceutical companies, for example, again, in the United States, I don't know whether this is prohibited in Canada, will prescribe certain drugs because the companies are paying the physician to enroll patients with those drugs. And sometimes physicians will get as much as $1,500 or so a patient to essentially prescribe a particular drug. Well, again, you say, well, look, don't you have a right to know that in advance, that basically that's the basis on which he's prescribing the drug and all? But certainly they're not upfront about that, and the websites are a particularly egregious example of this. Here's reasons for not using remote disease monitoring: cost, again, and MD-patient relations and all. Whoops. This says rapid pulse, sweating, shallow breathing. According to the computer, you've got gallstones. There are other problems, too. I mean, interoperability of information systems that I mentioned earlier is certainly is an issue. Here's a a case that came from out in Portland, Seattle area, where a 35-year-old woman who worked for one of the companies out there, information technology companies, was admitted to an ER with a high fever, and when her blood pressure dropped, essentially they transferred her from the ER to the ICU. Well, the ER had one information system, and the ICU had a different information system, and in transferring, something got sort of dropped, because when they ordered an antibacterial medication, the pharmacy filled the prescription with an antiviral medication. So this woman suffered irreversible brain damage as a result of it. And so, I mean, this is, again, is a very graphic illustration of this problem of interoperability. I did a lot of work with a large hospital, teaching hospital in Indianapolis. They had one system for the inpatients, they had another system for the ER, they had another system for the ambulatory care units, they had another system for the lab system, and they had another system for the radiology. None of these systems talk to each other. I mean, virtually they were all independent standalone systems, and so this issue of interoperability is certainly a major barrier to creating the kinds of electronic medical record systems that we would like to have. This says, I give up, where's the patient? In other words, the technology, in a way, can get in the way. I mean, as wonderful as this technology is, and as much as we're convinced that this technology is sort of the future of healthcare and medicine, and all, the technology certainly can get in the way, and physicians understand that. Here's a case that happens out at Cedars-Sinai Hospital in Los Angeles that's very much on the forefront of developing wireless electronic medical record system. Talking to the chief of staff and the head of medical informatics there, this system basically would provide access to patient records, physicians from anywhere, their automobile, their home, they're at a clinic, in the hospital, and so on. But basically what happened was that after putting in this system, and it cost them $34 million, the physicians rebelled and just about tarred and feathered the chief of the medical staff, who was a real advocate for this system. What were the problems? Well, they said out of 2,000 doctors who had privileges at the hospital, only a very few were involved with the development, the implementation of the original system. That staff complained that the system, the old system, that paper-based system would only take them maybe 3 minutes in all to complete some of the orders and so on. Now took up to 30 minutes through using a whole series of complicated screens. And they said the automatic alerts just drove them crazy, that every time there was a lab value that was out of range or anything like that at all, they got an alert. And so what do? Eventually they either turn off the alerts if they can, and if they can't turn off the alerts, they ignore them. And so basically, while these alerts and reminders, electronic alerts and reminders can be of significant value, we still haven't worked out a way of sort of separating the really important ones from the less important ones that drive physicians crazy. And so they basically had to pull the system out and try to put it back in before, and make a lot of changes in it. So what do you do about this? I mean, what do we try to do about it? Well, it's not easy. I mean, as far as individual hospitals and centers, certainly some of this is fairly obvious. Broad physician involvement in the selection and implementation, not just physicians, but pharmacists, nurses, others and all, who are going to be dramatically affected by the system. Clearly having sponsors or people within on the nursing staff, the medical staff, and so on, who are major sponsors of the system is important. Figuring out in advance how the system is going to affect routine practice patterns. If we go back to the Cedars-Sinai example, if essentially physicians were correct and this had that kind of an effect on them, clearly this is something that should have been foreseen before they put the system in, that the time involved in entering orders and so on was going to be appreciably longer, and this was going to negatively impact practice, and the fact that these alerts were going to be a real problem should have been something that was foreseen by some kind of evaluation up front. implementation of applications in stages. In the Cedars-Sinai system, they put the whole system in, and all the wards in the whole hospital, bang, and it was a disaster and all. Some other hospitals that have implemented these systems have done it on a stage basis where they not only just implemented certain features of it that physicians would find useful, such as retrieving lab results and so on, before they put order entry and some of the other things in, but also they tried it out on a ward or so and then used that experience to make modifications and changes before they put it in on other wards and so on. And so some kind of rolling implementation allowed them to foresee some of these problems and all. Also having a mechanism or a system to handle a host of behavioral and organizational changes that occur and all. Two other systems that were massive failures occurred at the Foothills Hospital in Calgary and another one at University of Virginia Medical Center. Both of those systems had to be virtually pulled out after they were implemented because of physician opposition and opposition from the house staff and all. In some cases, it very much disrupted the medical education process and so on because for example, medical students could not put orders in and orders could not be executed until they were officially signed by the attending physician. And features like this just had an enormous impact upon the workflow in these cases and had not been foreseen and caused lots of problems. If we look at U.S. federal efforts, I mean, there are some efforts here. The Consolidated Health Informatics Initiative that was announced in 2003 is an effort to standardize clinical coding schemes across federal departments and with the hope that vendors will begin to do this too, using things like HL7 and DICOM for radiological data and SNOMED for terminology, nomenclature, and so on. Another initiative by the federal government in the United States is to make the Veterans Administration system available to hospitals, and also a system that the American Academy of Family Physicians has endorsed as on an open source basis to try to reduce the costs, especially for small practices, rural practices, public hospitals, and so on, that would have a very difficult time affording the implementation of these systems. So these are some efforts. But given that, they're really not enough, because essentially some of these still don't provide incentives to the outside vendors to standardize their products and make them interoperable. And so that's still a major problem here. So what's the future of federal health information policy in the United States? Well, here are some proposals that have been made that establish as an objective the adoption by healthcare providers of EMRs that meet standards. In other words, that the federal government should set standards and even essentially begin to provide support, financial support for those healthcare providers who will adopt systems that meet those standards, that especially for collecting and exchanging clinical information. For the federal government to help subsidize some of the groups that are trying to develop standards for record structure, messaging format, and medical vocabulary. I mentioned 3 earlier, but certainly tens of thousands of procedures and so on in healthcare are a real challenge. And even though HL7 has moved a long way in that direction and the new version of that, version 3, will go even further, there still are problems there because lots of times HL7 and some of these other systems are modified by the individual organizations and providers and adapted to them, which then, of course, defeats the whole purpose of having a standard. If it's modified and maybe it works well at your institution, clearly it may not be then interoperable with other kinds of providers. Establish a form to notify vendors and users of new mandates by the government well ahead of time. Provide financial support to these standards groups. Another thing that we have in the United States, it's a barrier here, are these fraud and abuse statutes and all that essentially limit essentially cooperation between physicians groups and between physicians and hospitals. And so one of the proposals is to remove these barriers so that hospitals maybe can share their systems with physicians who practice in the area and who then essentially admit their patients to the hospital. Of course, this raises the issue about what happens if the physician also practices at other hospitals in the area and admits patients to other hospitals, and those hospitals have different systems. And so this gets us back into these issues and problems about interoperability. Again, to overcome this cost barrier that came up over and over and over earlier, the proposals are that the federal government should begin to try to provide some kind of financial assistance, maybe on a matching basis, especially to hospitals and physicians who don't have the resources to do this. That's a dilemma because essentially some of the large hospitals and providers and so on do have the resources, and so certainly there's a fine line here between essentially subsidizing them when they could virtually do it themselves. But certainly some financial subsidy program is going to have to be developed to get practitioners to do this. Also the HIPAA, which essentially was passed and finally enacted a couple years ago, really foreshadowed essentially the modern internet kind of use of systems and so on. And so it basically only covers standardizing electronic claims, and it doesn't really essentially cover the standardization of other forms of exchange of clinical data and so on. So it's already it needs to be essentially updated. So with that, I'll quit and let you have an opportunity maybe to tell me a little bit about your experiences and such.
Thank you. I'm going to be the poor substitute for Dominic Covey in doing the question and answer period. So I would invite you to ask your questions. And if you wouldn't mind, let us get to you so that you can be recorded on the recording with the mic. So any questions from the audience? Dawn.
There's obviously many barriers to adoption of this stuff. I mean, that's clear enough. But it seems to me one of the barriers that exists right now is that the person who is, we would like to adopt things like electronic medical records, et cetera, don't see any short-term benefit in doing it. I mean, there may be a long-term benefit in that, wow, your office will operate much better 10 years from now or whatever. But they don't see any, I'll say material benefit, but it could be other benefits as well that come back to them immediately for adopting this kind of, I wonder what your comments are.
Yeah, that's really an important point, Don, because it's interesting, instructive to sort of ask, make some comparisons here and say, well, why did we have such a rapid diffusion of technology like MRIs and CAT scans and so on, certainly in the United States? Well, one reason is that physicians could bill for that, and so certainly that became an enormous revenue-producing center for physicians. In fact, physician groups, set up their own imaging centers, sometimes freestanding kinds of imaging centers. There's one in the community where I am that's sort of like almost a drive-through one right next to McDonald's. It's almost like you go get a hamburger and then drive through and get your MRI, next door and all. But clearly there was a tremendous economic incentive for them to adopt that kind of technology. But in terms of information technology, many times the revenue is separate from the providers and all, and even though you can say, it's going to save money and all, they don't see that. It's not something they can bill directly for. So possibly the insurance companies or the managed care organization will derive economic benefits from this, but the provider himself or herself do not see the benefits to the bottom line for them. I'm not saying they're venal or anything else. I mean, for small practices, that's a very real consideration, that if I invest this money up front and on a continuing basis, is this just an expense or is this something that it's going to, at least pay for itself over a period of time? And they don't see that. They realize this is going to be a big expense, but they don't see the return on that investment at all, and that's a big impediment.
Oh, hi, I'm Dennis Egan, CEO of one of the local hospitals here, and just a comment first and then a question. The comment is, when we went to electronic billing for physicians to the provincial plan, they used to do it paper, and the government basically said, you submit it electronically or we're not going to pay you 100 cents on the dollar, and I can't remember, and they very quickly converted, so I think there's a message there. The question I had, though, was, as a CEO, one of the things that drives me nuts is the cost of implementing these systems is astronomical, and obviously there's the software and the hardware, but a big part of it is this education of the people. It's a huge cost. And I think back to, we don't have an education seminar on how to use eBay or, book an airline ticket or on and on and on. And when are we going to design these systems, or was there any work being done to design these systems so they're intuitive and that we're not having to spend hundreds of thousands of dollars to train nurses and everybody on them?
Yeah, I think that's an excellent comment. These are really complex systems, and the training costs. Also, essentially, we were talking earlier, and all just like at home, updating software, managing this on, what do you do when the system goes down, having essentially the technical staff to troubleshoot and so on. All of these are additional costs, and so there's a substantial ongoing cost for a hospital, the size of your hospital, as well as for just these providers like my daughter and her partner and all that. And all of these are real impediments, and certainly a lot of physicians would need some kind of training, and so they're talking about should that be provided through some of the professional associations or something would provide that kind of assistance to hospitals and all. But then again, who's going to bear that cost? I mean, where's the money going to come to bear that cost of training? I know in one situation, the health system out in Salt Lake City there at the LDS hospital and all, they ran into problems when they tried to export their system, the health system, to some of the other Intermountain hospitals because physicians didn't want to be trained by nurses and technicians. Physicians wanted to be trained by physicians. So they eventually had to go to pairing a physician from one of these sister hospitals with a physician from the LDS hospital, which is obviously very time-consuming, very expensive. So I don't know what the answer is to that, but that certainly is a barrier.
I'll just take a moment to say to people coming in via the web, I welcome your questions. Just type in your questions to us, and I will ask our speakers. So get those fingers going. So.
Thank you for your presentation, Dr. Anderson. In Ontario, many of the things that you talked about are exactly the same here. Part of the problem, the barriers to adoption, is that the average age of physicians in Ontario is in the mid-50s, 54, 55. That presents some issues in terms of cost. Is it cost affordable up to the point where I might leave practice? Secondly, the change management effort, the conversion of records, staff training, data entry methods that they have to learn, and the change in workflows are huge issues. On the other hand, 99.4% of claims that are submitted, and there are 12.5 million to 13 million claims a month, 99.5% of them go in electronically. 86% of physicians submit them themselves, and another 10% have a billing agent do it on their behalf. 4.5% of them are still using cards. Now, the 4.5% are submitting 0.5% of claims, which means that they're low-volume billers. They're psychiatry or anesthetists or close to retirement or moonlighting or something. But essentially, we're automated in an administrative sense in Ontario, but we're not automated in a clinical sense with only a small percentage, 5, maybe 6% of the profession using electronic medical records in a clinical environment.
Yeah, that's an excellent observation. But that's also probably an area where physicians do see the cost savings to them, because I imagine that physicians' offices here, just like in the United States, if you go in, they have half a dozen people handling the claims and so on, and then having to justify claims and filling out different claim forms or submitting, since that's not standardized, that there's an enormous overhead. I think the figure I saw just recently, they estimated in the U.S. system that roughly 30% of the healthcare costs, which are astronomical, and they're rising at about 10 to 15% a year, goes for just this administrative kind of overhead. And a lot of that is things like claims submission and justification and so on. So it's certainly an area I think that physicians see the advantage of having some standardized electronic claims submission process. And so that may be an area that moves ahead fairly quickly in the United States. But we have so many different billers. When I was up at Mayo Clinic, they said they have, I think, over 1,000 different plans, that they deal with essentially with patients coming in there. And so that just, of course, you can imagine what the overhead cost to them is of dealing with all those different insurance structures and systems.
If I could just add a couple of points. The ministry provided an incentive to the profession to move initially from cards to diskettes, and what the ministry called an incentive, the profession called a disincentive, in that it was 50 cents a claim card, which has now become $2 a claim card. And so it doesn't take very many claims before a physician says, I have enough claims here to justify using a computer system, and that's why there was the movement, as the person behind me mentioned, the movement to submitting claims electronically. So the efficiencies have been gained at an administrative level, but not at a clinical level, as I mentioned.
Any other questions?
I think back here.
Oh, here's one. Okay.
We've been doing some research on electronic medical records, electronic health records, and getting them out of the hospital into other points of care, like home health care providers. One of the experiences we had was with U.S. Army hospitals, where we see a system called DWIMIC, and they put the medical records on little SD cards, and they hang on the warriors' kind of dog tags, and if they get hit or whatever, they have their medical record there. Another thing that I've seen in the UK, which is my question, there's some third-party service private companies popping up that will store your electronic health record outside of the hospital and other care providers, so that the individuals can now become the custodians of their own electronic health records. Do you see any kind of legislation or grassroots movement to people taking ownership of those records and that happening in the States?
No, I don't see any legislation, but there certainly are some private providers who will do that, essentially create an electronic medical record, and of course they argue then that's accessible if you're ever in an emergency situation and all. Probably one of the limiting factors to that, and it's been slow to catch on, is that then, at the other end, if you end up in an emergency room or with a physician and all, they have to have the software to be able to essentially read that. So again, not having some kind of standards there, not having essentially the software and all that would be necessary to read that limits the use of that. It would be fine if you could always go to the same healthcare provider and your chip or card or whatever was readable, and they had the readers there that would do it. But that's a real problem. So it's been very slow to catch on. Our survey indicated only a few % of people indicated that they had anything like that at all. And I haven't seen any indication that there's legislation that would try to encourage that again.
I understand the importance of having standardized health records so that you have interoperability. How could you move the companies, though, to standardize? Because some of their proprietary nature is going to help them with competitive advantage. So how do you see being able to incent them to move to something that's more of an open standard, and that they can't necessarily get obviously within their own systems they can get a lock on various health regions and so on to be able to take care of all the records, but
yeah,
obviously open to the
that's going to
market.
be very difficult in the United States because of the competitive nature of the system and so on. The proposals that I've seen are that the federal government would virtually have to provide major incentives to adopt systems that met some kind of federal standard Even those proposals don't go to the point of legislating that you have to adopt them, but essentially argue that you'd have to essentially create some significant financial incentives so that if people are going to purchase a system or implement a system, they're going to implement a system that meets those standards. And in a way, that's a backdoor way of sort of forcing the vendors, you know, if they don't see the market for their individual products, it's a proprietary system, that maybe they'll get on the bandwagon. So that's sort of a convoluted kind of way of trying to do it. But I haven't seen any proposals that, as I say, would literally legislate, here's the standard and you have to use that. So I think we've got a hard problem here, a difficult problem to deal with in the United States. I don't know whether anything in Canada, how you would deal with this in Canada.
Earlier there was reference to the Smart Systems for Health Agency. Part of the Smart Systems for Health Agency, one of the responsibilities is to run the Ontario Health Informatics Standards Council. It has stakeholders from every healthcare sector. 22 representatives sit on this council, and we determine, we evaluate different standards, and they're either technical standards, communication standards, data standards, or clinical terminology, nomenclatures and classification schemes. And those, each sector representative commits to using their best efforts to have these standards used throughout their particular sector. And as new technologies are rolled out, as new programs are rolled out, these standards will become ubiquitous.
How successful have you been?
It started and it's working so that in order to communicate with government, these various agencies, other parts of the healthcare community, in order to communicate with government, in order to be paid, then there's a requirement to get in line.
I'll get the mic from you in just a second. We do have a question from the web, and perhaps you could give a comment on this. It seems that one of the reasons for slow clinical and organizational acceptance of information technologies in healthcare, for example, computer-based decision support systems, electronic medical records, etc., is the lack of evidence of effectiveness of such systems on patient outcomes. Additionally, many current studies in health informatics use non-adequate designs or are methodologically flawed, bringing more uncertainty to policymakers and responsible for evidence-based questions. Perhaps you could comment on that?
Yeah, that's a good point. That you know, we've talked a lot about it, but there just is not, as you say, as the individual here indicates, to indicate that that you really do have cost-effective systems. In fact, given how much money you're going to have to invest up front in one of these systems and then the continuing maintenance of it, you're investing a lot of money in it. And so it's not intuitively evident or obvious that you're going to save money in any real sense, and probably not in many cases. But also, I guess the argument about clinical outcomes, probably one of the few areas that there is growing evidence is certainly on medical errors. A lot of the work that's been done by David Bates, for example, up in Boston, certainly indicates that you can cut medical errors if you implement these systems. But even that, the technology only goes so far. One study that we did at a teaching hospital in Indianapolis indicated that you can get, just with the technology, like using things like physician order entry, using barcoding of drugs and so on, that you might cut medical errors maybe 30% or so. So there still is a significant human side to this. And I know Dave and some of the studies that they did indicated that if you then add to that, like a clinical pharmacist who rounds with, you can significantly cut the number of medical errors, especially drug-related medical errors and all. So certainly medical errors is one area I think there is growing evidence and all. But as far as other kinds of clinical outcomes, I think so far the evidence is sparse, unless some of you know some more about some of the studies that would support that. But it's pretty sparse.
Kathy, did you have a question?
we're doing some research in Toronto right now, looking at EMRs in a ward in Toronto. And one of the things that we've really become aware of is, first of all, that the EMRs really don't clearly support a lot of clinical activity. Mm-hmm. They actually prevent or make some kinds of clinical activity more difficult. Mm-hmm. And that's because the EMRs actually don't really reflect the whole tradition within medicine of the record itself. The record itself has a very long history in medicine, and of course physicians are trained quite rigorously to fill it in and to reflect the structure of it, and it's even complicating. In fact, we're seeing the EMRs being used as gigantic printers, and we're seeing a whole roll of paper records, and I'm wondering whether or not it would be more appropriate to think about a more constrained role for EMRs rather than this huge vision that we have, to think of, especially in hospital settings, it seems to me, where it's really, really critical. It's critical for another reason, too, because that's the place where young doctors get their training. And that's where they're first introduced, in fact, to EMRs, and the whole possibility of EMRs. And they all go through that. But right now, the EMRs are not supporting their practice as nearly as much as they want to, and they're really fighting it. They're finding all sorts of workarounds to kind of fight their way through the system or around the system, manipulate the system. They're doing things in unaccountable ways than we'd ever imagined.
Yeah, that's an excellent point. Electronic medical records and like computerized physician order entry and so on sometimes really disrupt systems that have been put in place to, for example, checking on this medical errors and so on. A good example of that was one system, one hospital essentially contracted with an outside company to put in a pharmacy system, and they took a warehouse inventory system and converted it, because to their way of thinking, handling pharmaceuticals was the same way as handling widgets or automobile parts or something else, and they implemented this, and it was a disaster. It was a disaster primarily because all the double and triple checking that took place before was superseded, where if the physician made a mistake, the nurse was likely to catch it, and if the nurse made a mistake, then possibly the pharmacist would catch it or something. It sort of superseded all those kinds of informal relations and ties and all that are sort of built into practice, and then everybody got into the blame game. I mean, the pharmacists blamed the nurses blamed the doctors. Nobody would assume responsibility for the errors and all. And they literally, again, had to pull the system out. So it's a good point that and just that example that I gave earlier, where they found that that system they had at University of Pennsylvania had lots of problems and all in terms of physicians ordering, even physicians ordering drug for the wrong patient. You say, well, how could that happen? Well, apparently there were just flaws in the software and all that caused problems like that. So these are real barriers, and so certainly just having a super EMR is not the be-all and end-all or the answer to everything. Lots of times, too, maybe the nurses like the system because essentially it helps them. They don't have to sort of decipher the cryptic writing of physicians and also their prescriptions and so on. But physicians hate the system because they said it takes them longer, or they can't write essentially orders the way they have traditionally written them. I mean, if all you're doing is getting a menu with a point-and-click kind of thing, that it's standardizing the way orders are written, but this is not the way I do things. I mean, I've always written my orders this way. And so there certainly are a lot of aspects of this that are really knotty to work out. Having said that, I must confess again, my experience with the health system out in Utah at the LDS hospital, there's been a remarkable acceptance of that system, and it's a very advanced system that even issues reminders and alerts and even scans the medical records of patients every day and predicts which patients have high probabilities for nosocomial infections or for adverse drug events and so on. And it's used on rounds. When I rounded with physicians out there, I mean, they pull up the electronic medical record, and project it on a screen and talk about it, and they can pull all kinds of information from lab results and scans and so on. So that certainly has been accepted over time, but it's been in development for a very long time. Also, it was initially developed as a clinical system, not as an administrative billing system. Most of the legacy systems were really developed as billing systems, and the clinical part of that was added on later, and that's really been a problem because they still are largely handle billing, administrative kinds of data and so on very well, but they still do not handle clinical data very well, clinical transactions very well.
I think Kathy will comment or could comment about some of the other experiences from her research and her graduate student, Laura Varpio, who gave a very interesting seminar just last week. And, you know, some of these systems are so inflexible that people want to write little margin notes, and they, you know, they want to put little diagrams in as reminders, and how many of our systems are able to cope with that sort of thing.
One of the comments, and Dennis made the comment earlier about why does it cost us so much in training? Frankly, because I don't think we know how to build these systems very well. We are trying to build systems which are very complex because mostly you sit in front of something like eBay, and it's just you and the computer. But here we're building systems where a lot of people interact, and we don't understand how they interact very well. And hence the systems themselves, I think, we just don't know how to do it very well yet, and we've still got a long way to go. Let you have your rebuttal or whatever just a second. But there was one other comment. We noticed that in your charts, we got high penetration in certain countries of certain technologies. I think EMR, for instance, was some ridiculously high number, so to speak. Do you have an explanation for that? Or?
Well, probably the most basic one is, you know, there's single-payer systems, and basically, you know, if, like with the UK, I mean, they've made a commitment for everybody in the UK to have an electronic medical record, and they're investing about $12 billion in that. So every practitioner, you know, primary care practitioner is part of the system, whereas, of course, as you well know, in the United States, it's just such a heterogeneous system, you know, with so many payers and all independent, and then add to that, you know, Medicare and Medicaid, the federal government and all, and so each practitioner pretty much, or healthcare provider, has to make that judgment pretty much themselves. There isn't any sort of federal mandate, or there's no federal funding for this. It's pretty much an individual decision, and small practices make that judgment about whether there's going to be a return on investment, and so far we have not convinced them that the return on investment is significant enough for them to invest in the system. So, I mean, that's my answer. Maybe some of you have some other insights into this problem.
I believe Dennis has a comment.
I was just going to comment. Like, I think the lady in front of me here has hit the nail on the head, and the first time I've ever heard that, because I'm not sure the electronic or the medical record has ever really worked well. And I can recall, you know, my experience at both Sunnybrook and Hospital and Mississauga before I came here. I was, as a VP, responsible for areas like speech pathology and physio and OT. And what happens is we train those people to do these wonderful documentation of what's going on with the patient, and the chapter and verse, you know, a page and a half. And I got news for you. A physician is not reading a page and a half physio note. And so I'm not sure it's ever worked, except when, you know, those small percentage of cases in Canada that end up in front of a judge somewhere, and that's when everyone attacks what happened. But, you know, really, I'm not sure the electronic records ever really worked well. And I think you've hit the head right on the nail right in front of me. Maybe we've got to reorient what it is this thing is for, and then design it accordingly.
Well, I think along with Don's comment, you know, we really haven't really thought it through, and also in terms of just how people work, the workflow that it's being implemented in, and so how does that be supported by these systems? We have another question from the web, somebody attending from the webcast. What are some research areas in the adoption of electronic health records?
Well, certainly there are many, but certainly just these last comments are one primary, and that's how do they fit into or affect or impede workflow. Clearly, that's a critical issue in implementation of this, and then there's three examples that I gave earlier of systems that really were dramatic failures after incredibly large investments in them. Almost all cases, these were workflow issues. Their physicians and residents claiming that it took too much of their time. In cases, they said, well, it didn't fit in with essentially the way they practice, where they would move from patient to patient. They would have to somehow take detailed kinds of notes, and then at the end of the day try to remember that and enter all that kind of information. I have another daughter who's a physician, our oldest daughter, who goes over from Ohio to West Virginia 1 weekend a month and spends about 60 hours essentially seeing patients, and she says she remembers all that information in her head and dictates notes and so on the way driving back to Ohio. And I mean, my mouth dropped open. I thought, my God, are you putting patients at risk? This totally depends upon her memory and trying to do that. And so this business that you mentioned earlier about how we can build this so that it fits into the way not just physicians, but these other, pharmacists, nurses, physical therapists, all these others, is really a knotty problem. And of course, all of them are different. And the way the information they need, the way they want it displayed, how it's entered, all that is different for all of these groups. So certainly I would see that as a major area for research. Certainly one of many.
Yes, go ahead.
Sorry. You did sort of touch on it when you were discussing the failures at other sites about rollout strategies and implementation strategies. I'd be very curious on your opinion on what's best. I know that a lot of times people want to go house-wide with everything, or house-wide with a few features of a specific product, or unit by unit and so on. I'd be interested in your input on that.
Well, I think strategies where I've talked to people to where it seems to work was, one, you have to give people something of use or value to them. And certainly, like physicians, I say, want lab results. I mean, lab results are one sort of low-hanging fruit, if you will, because essentially physicians want that information, and being able to access that information quickly and having some sort of a seamless interface with the lab system and all is a tremendous boon, because otherwise physicians are having to call or having to have somebody call the lab to try to get the results and so on, or they're having to wait until they're delivered and all. So that's an easy one, and that's something they immediately like and want and all. Certainly order entry is probably one of the last things that ought to be implemented, because this really changes things for physicians. I mean, it changes the way they enter their notes and their orders. They have to become familiar with screens and so on. Lots of times it's standardized, and they don't like that because it's not the way they're used to doing it. And so probably that probably creates more negative reactions early on than almost anything else. And so implementing things that they find very useful and they can easily see the advantages for them is certainly one strategy. And the second strategy I mentioned earlier is to do this gradually on one unit before going on to other units, because you can do an evaluation as you go and try to correct and head off some of the problems that you experience with one unit before you move to the next unit, before you move to the next unit. And so again, in some of the hospitals that have tried that strategy, they've been more successful too.
My field is economics, so I'm a little interested in the part of your conversation where you dealt with final customers or people out in the real world trying to get information that's useful. And I agree completely with your point, only maybe even more pessimistic. In economics, well, first of all, you're very familiar with the adoption rates, and people adopt things when they're useful. And I think that some of the commenters have hit the nail on the head when they're talking about time. If you take time into account, whether it's useful or not, then you get a pretty good explanation for why these things aren't adopted. But on the final user point, the famous market for lemons, a central part of that problem is that you can't, as a consumer, understand which of the sellers has got accurate information versus the one that's got inaccurate information. And I'm even more pessimistic than you are. You mentioned the notion of phantom sites, and people who look at this in practical terms now find it's too easy. We've made it very much cheaper to have phantom sites, you see. So the edge over the next couple of years is still going to be towards having more and more inaccurate sites out there giving us more and more bad information. One study that I saw recently was on insurance companies, and only 10 of the 35 were actually what they were purporting to be. So it's getting cheaper now to be dishonest. So I think the swing is pretty pessimistic on that, but maybe we'll come back to it. On the part of the angle back where you're talking about standardization, it does seem to me that we could learn from the other methods of standardization, and one of the comments here was on that point. The Great Baltimore Fire, the city burnt down because they brought in the fire departments from Philadelphia and Washington and so on, and the city was burning, but they couldn't put any of the couplings together because they're all different hoses and couplings. And we had to go to a sort of an autocratic, in American mentality, an autocratic rule saying everybody's got to have couplings that fit with the other ones. And that's seemed to be high-handed there, and probably in Thailand or something that would be just normal business, and you wouldn't be upset about rules like that. But the way we normally deal with standardization systems is the way that's suggested over here. You get the people together, including every single kind of user, and you go over it, over and over it. But sometime you have to come to a conclusion. And I think that the countries, like maybe South Korea, that have wireless standards that are a bit autocratic, are getting an edge right now over countries that are very much more democratic and say, let's have 1,000 standards, and 1,000 flowers will bloom. They'll all bloom for a month and they'll be dead. And meanwhile, the other system will be thriving. So do you have any notion of how we could go about, accelerating the sort of concept that there are benefits there and that it is worth our while to do a whole lot more cooperation than we've got?
Well, one possibility would be for the Center for Medicare and Medicaid Services, the old HCFA, now CMS, if essentially they were to basically impose standards and for Medicare claims and so on. I mean, that's one possibility if Congress, if our U.S. Congress doesn't basically prevent them from doing it. And given, our present administration, so it's hard to see them allowing, those agencies to use the clout that they potentially have. But certainly they account for more and more of the funding for health care, especially as we're getting more and more aging population. And so that might be one mechanism of trying to begin to impose standards. Now that doesn't say, well, what about those people who aren't covered by Medicare? Well, a lot of hospitals are so dependent upon, for example, Medicare funding that, 50% or more of their funding is from Medicare, that it would have a lot of clout with the hospitals, more so maybe with the like the primary care providers, so that that's the only answer that I could think of as a way of beginning to sort of, as you say, have more clout and not just a voluntary effort, but to essentially put a little bit more federal initiative behind this and force behind it.
Well, we've come to the end of our time. Unfortunately, it's been a very interesting talk. I thank Jim very much for coming today. I've enjoyed the questions and comments immensely, so thank you to the audience for participating. Thanks to the people coming in from the web for their comments as well. And I look forward to seeing you next month on May 25th. Thank you all for coming today.
Thank you for coming.
Thank you.
Thank you.